Leigh, tell me a bit about your early life and how you got into your medical career.
And thank you, Mike. I grew up close by to here, about 2 miles away. I was the eldest of 7 children, and my father was a wartime general practitioner with an appointment to the Mater Children's Hospital as a GP surgeon after the war. You know, I had medicine all around me as I grew up. My grandfather from Melbourne was a Federation poet, but he did 3 years of medicine during the First World War and then dropped back to poetry. And his father, Prof Leigh Atkinson from Bendigo, had gained an MD in 1862, and then he moved to Bendigo, to the asylum there, and worked there until 1915 as a surgeon. And in turn, his father was a GP in Weaverthorpe in Yorkshire. So medicine was in the genes, I'd say. And I subsequently considered law, but did medicine. And of the 200 that started our year, 100 graduated. We were given a Commonwealth Scholarship, and then I went through medicine. Because my father was on the Mater, there were some other influences that ended up with me at the Mater. In first year, I won a prize, the John Lars Prize for the Resident of the Year, which attracted a neurosurgeon. Now, I wanted to be a paediatric psychiatrist, and that was something that I was keen on. And I thought if I did neurosurgery, I might learn a bit about the organic things. But he was a good mentor, and he encouraged me to go to Scotland. And so after 2 years with him, I went to Edinburgh to work with John Gillingham.
Yep. When you came back from Edinburgh, did you go back to work at the Mater after that?
Yes, I returned with the help of Sir Douglas Miller, and who was one of the presidents of the College of Surgeons, and he was the mentor for Jeff Tokley. I was appointed as a neurosurgeon to Dr. Tokley, who was Brisbane's first neurosurgeon, and so he was my mentor, my teacher. I eventually was his partner in his practice and a close friend of his, so it was a big bond.
Tell me about how a surgeon ends up with a rehab fellowship.
Well, when I was at the Mater, a senior paediatric physician, David Jackson, encouraged me to attend the Queensland Spastic Welfare League once a week on a panel with a psychiatrist. And so there was again a multidisciplinary approach that I was given, and I would sit on this panel at the Spastic Welfare League each Wednesday afternoon. And so that went by, and then I was involved also with spina bifida, because at that stage we had so many spina bifidas in our public hospital wards, and I helped set up a spina bifida association for Queensland and then Australia. And then I was involved with setting up a craniofacial unit that we did surgery for, and of course I was in rehabilitation of head injuries and spinal injuries and motor neurone disease. So with all of those sort of things going on, in 1981 when they established the Faculty of Rehabilitation Medicine, I was asked to be a foundation member. And so, in turn, that got absorbed into the College of Physicians. So I stayed on with the College of Physicians. And so, similarly, I was a foundation member of the College of Anaesthetists, and so I stayed on with them.
So a lot of your early influences were other neurosurgeons who were deeply interested in pain.
Yes, because pain was a big part of neurosurgery in the 70s and 80s. It died out at the end of the 80s.
A lot of neurosurgeons might be surprised to hear that these days.
There's not many. There's very little pain done in neurosurgery these days, excepting trigeminal neuralgia, where we have a very, very good results from 2 or 3 procedures.
So Leigh, tell me a bit about how pain was managed when you were a resident in the early days.
It was managed predominantly by neurosurgeons, and we got the referrals.
This is chronic pain?
Chronic pain. And of course, there was a book written by William Sweet, a professor in the United States, called Pain and the Neurosurgeon, and that was influential to the neurosurgeon. And so we had a large number of procedures like open chordotomies, sympathectomies, rhizotomies, mylotomies, and in 1965 or 67, Shealy brought in percutaneous chordotomies, which my mentor at the Mater, Jeff Tokley, was probably the primary introducer to Brisbane. There was a vast number of interventional open pain procedures. We didn't have much evidence to support that, but we were doing it. And by the end of the 80s, we had decided that there was a different way to go when the multidisciplinary approach was starting to gain a lot of momentum. And really that goes back to the 70s, and I was travelling a bit around Australia, and I travelled to Adelaide, and I went to the Royal Adelaide Hospital where I watched at a pain clinic which was run by Donald Simpson and Issy Polovsky in the anaesthetic department, and that was pretty impressive. And I got friendly with Issy Polovsky, a psychiatrist, who was famous for...
He coined the term abnormal illness behaviour.
Abnormal illness, yes, thank you for reminding me. Abnormal illness behaviour. And Issy in turn seemed to pass me on to Michael Cousins. And so I started visiting Michael Cousins' unit at the Flinders and talking to Michael about pain. And so at that stage, Michael was being interested in the International Association for the Study of Pain. And in 1979, he was the first president of the International Study of Pain section in Australia. We changed the name to the Australian Pain Society in 1982, and I was the president from 1983 to 1986. So Michael and I, and then David Cherry and others from Adelaide, Penny Briscoe, all were networking about that time. That, of course, led me to get more involved with the International Association for the Study of Pain and anaesthetic people. And so while I initially, when I returned from overseas, I was wanting to be a paediatric psychiatrist. And I thought I'd do neurosurgery just to pick up some organic information. But I had a mentor that pushed me the other way, and then Sir Douglas Miller in Sydney helped and have me appointed to the Mater when I came back from Scotland in 1970. So Michael Cousins coming in Adelaide during those training years and during the 70s, and I linked up, and the Australian Pain Society was our, where it sort of became more institutionalised.
So the Australian Pain Society was very successful and continues to this day. Tell me a little bit about the people who crystallised the idea that a faculty of pain medicine needed to happen.
I don't think there was any thoughts of that during my training in Edinburgh, but I did move around to meet some pain people, particularly a man called Bill Norton-Boss, who was from Holland, a neurosurgeon, but he was moving that way into chronic pain. There was Norton-Boss, there was Hitchcock, and these sorts of surgeons were influential at that stage. And then other international neurosurgeons that I got involved with. I suppose towards the end of the 80s, it was Bonica in Seattle that changed our philosophy and changed our practice. So we moved away to multidisciplinary pain clinics. And by that stage, I had shifted to the Princess Alexandra Hospital, where I started a neurosurgical unit. And I also started a multidisciplinary pain unit with Graham Rice as the psychiatrist and John Weeks as an anaesthetist. And we started that as a multidisciplinary exercise, and that gradually gained momentum too. So I could see the way it was going away from surgery and to the multidisciplinary approach. It grew in the 90s so that Michael Cousins, now on the board of the College of Anaesthetists, started managing a direction, and he got the college involved in that. At the time I was Vice President of the College of Surgeons, and they put me on this group with Michael Cousins, and so that I was nominated as a foundation member to the...
And that was the working group, wasn't it? The ANZCA working group that led up to the...
At the end of the 1990s, that working group was going.
What was the thinking behind the Australia-New Zealand model of a faculty with a very multidisciplinary or multi-ecumenical, if you like, approach? In other countries and other areas, it's remained largely a subspecialty of anaesthesia. But what was different about the Australian experience that we decided to do things somewhat differently?
Well, I think that was really the genius of Michael Cousins. He was on the board of the Australian New Zealand College of Anaesthetists, and he was thinking that we could expand it. He got these 4 colleges together, the College of Anaesthetists, the College of Surgeons, the College of Psychiatry, and the College of Physicians together. I think the initiative absolutely came from him and then the College of Anaesthetists. The others didn't have so much interest in it, no interest in it, some I'd say. Even harder to get the psychiatrists involved, and the College of Surgeons was happy to give it over. And mind you, the president of the College of Anaesthetists was on the board of the College of Surgeons, so there was a bit of a link up there that made it easy. The College of Surgeons had 10 different specialties. The College of Physicians had probably the same number, and so they didn't have the driving interest in getting more. The College of Anaesthetists, on the other hand, had just one specialty, and they were watching these others grow and have all these other involvements. So they probably needed something like the Faculty of Pain Medicine, but they didn't have a lot of skills in handling another group. For example, it's very hard to get the Dean of the Faculty of Pain Medicine onto the board of the College of Anaesthetists, although it was a specialty. So that was one of the frustrations, I think, in the early years.
So looking back through your time as Dean, as the second Dean of the faculty, some of the issues that I see when I look at the minutes from those days have not changed at all, such as the difficulties of assessing overseas trained specialists to come to Australia, maintaining training units and accrediting training units. There are a few things that have changed, and one of the things that featured prominently then was election of fellows and the process by which people's prior experience was assessed and they were directly elected. Some which I imagine went smoothly and others which were more contentious. Were there any memories you have around the debates about electing some individuals or the principles behind how we had to elect people?
I think all bodies have this problem. The College of Surgeons had this when the general practitioner surgeons, who do you recognise as a surgeon and who do you don't, when there's so many of them. Certainly, when the faculty was rolling on, we needed to pull in people who had some significant influence in pain clinics. I mean, there was anaesthetists that have got just a single clinic in Sydney, for example, Brian Dwyer and Tess Brophy in Brisbane. They were the dominant person driving the clinic, but they weren't interested in sucking any other specialty in. And so, yes, it was difficult at that stage, selecting who might be appropriate as foundation people and keeping that growing. And it still remains a challenge how we handle these other colleges. And, I'm particularly aware of that now, 24 years later, with the College of Surgeons and the College of Psychiatrists on how we keep them in the body.
The other thing that was particularly prominent during your time as Dean was preparing to become a full specialty recognised by the AMC. What was the feeling on the early board about how important it was to get recognised as a specialty and what would be the characteristics that define our specialty?
Well, listen, I think that was critical. It was vital that pain medicine becomes a specialty, but we had to work with the AMC and go through the loops and barriers that they had extended, and we had to set up examinations that were equivalent to examinations of the other colleges, and we had to set up training programs that were equivalent. I suppose the basics during my time was trying to ensure that we had pain clinics in the public hospitals around Australia, and we were trying to get them in Queensland, New South Wales, Victoria, and these places, and trying to get staffing of those clinics. So I recall big issues in trying to develop the public hospital pain clinics, not so much private at that stage, they would come later. But we pushed for that, and then there was the examinations, and of course again, some people had trainees, and if they didn't get past, they were fairly aggressive and upset about that. And so that was another issue at the time. And then there was the politics of it. And the politics came a little bit later, but I recall, we had a superb meeting arranged by Michael again, predominantly, in Canberra in about 2010, in the Great Hall with the Minister of Health there.
Yep.
And it just emphasised again our need to work through politics if we want to get health systems changed.
Yeah, and that was something which certainly was there early on, and perhaps sort of dropped away a bit after that decade, after the National Pain Summit, and that was when Pain Australia was created.
Well, that's an important point to make, because, one, we have to work through politics, but two, there's a lot of people in the community that see a place for these things and they want to drive it too. So, again, it was Michael Cousins who really established Pain Australia as away from the professionalism and with the common man out there to see people who are influencers and who might support pain management. So Michael had a great CEO working with him in Pain Australia, and he got the business community and significant leaders involved. But these patient support groups can be pretty dangerous at times as well, and then they always keep springing up. So we had Chronic Pain Australia, which was fairly difficult, and then we had the Australian Pain Management in Brisbane, which has been a bit of a sleeper. But as things have changed, Pain Australia has taken a back seat, and the Australian Pain Management Association is getting a big influence in Queensland and Victoria. And these operate with the government in getting things like, the most recent thing, of course, is the pelvic pain clinics, which are growing a lot of momentum in some of the states, particularly if you're lucky enough to have a health minister who's a female. Well, it's really driving it. So that's been a recent positive.
Now, we have some photos with us. Maybe if we start with the largest one there, the photo of Patrick Wall. He was a wonderful man as well as a great scientist.
Well, he was a great enthusiast, been partner in developing the pain control theory, and we had a lot to thank him for.
So this photo here, taken in Hong Kong in the 70s, I think.
Yes.
Yeah, tell me about that photo.
I did travel a lot because Gillingham had so many international friends around the world, and he trained a lot of people in Scotland, having been the second professor after Norman Dott, who, interestingly, one of the first neurosurgeons in Britain, one of the first three, he'd had a cordotomy. And I was in Edinburgh, and Norman Dott would come to all our meetings, and I'd talk to him. I even ran a spina bifida meeting to fund a spina bifida, and he chose twins as the ones to win the baby competition, which was a bit of a conflict between me and him, who should win. Anyway, he chose them. But I had that Norman Dott, and I had all this Gillingham contacts. So Gillingham arranged for me to go to Holland, to Amsterdam, to see a man called Bill Norton-Boss, who was a very influential international writer on chronic pain. Now, some years later, I'd kept in contact. I travelled to Hong Kong with Bill Norton-Boss to see surgery there, pain surgery. And we were taken to St. Teresa's Hospital on the Kowloon side to see a transcranial section of the trigeminal nerve. Trigeminal neuralgia was a big problem, was a suicide disease, and we went there to see this. Now, they were showing us acupuncture at that stage, and so it was an operation under acupuncture, and I watched this Indian man who didn't speak English go to the operating theatre, and they gave him the anaesthetic, which was under acupuncture, and then Henry Wu commenced the operation. He cut through the skin, that was clear, and he cut through the bone, that was clear, and he touched the dura, and the patient jumped off the table and ran away. I never knew what happened to that patient. But we went to that, so that was another international experience when you go to different places.
And this photo here's with John Loza, who was very influential within the IASP. What did you learn from him?
Well, the wonderful thing about John Loza was just a little paper he wrote with the Loza rings. And it began with, pain as the central problem, and then suffering, and then disability. And then there was the stresses all around that, the social. So that was a wonderful teaching thing because it kept it simple for surgeons, and that was pretty helpful. John Loser, of course, worked with Bonica in Seattle, and they were close together, and no doubt he was influenced by him too. So he was pushing to the neurosurgeons around the world, like Bonica was, that pain was much more complex and needed a lot of other things to be thought about, like patient selection. And so I had some contacts with John Loser over some years in the 80s and 90s, and Bonica, and came to Brisbane and came to Melbourne for some meetings, and we got friendly that way. I have quite another picture of Bonica up on Mount Coota with his wife looking over the city, but I remember Bonica.
That's the photo there as well, with you and him and Izzy Palowski there.
Yeah, that's right.
He was the creator of the sort of model pain clinic, wasn't he?
I think he was the dominant influence in the 80s of pain clinics and pain management and the shift. And I think that revealed to a lot of us that things had to change, And I'd say to you, Mike, that really there's very little pain surgery done in Australia, excepting for trigeminal neuralgia. Now, trigeminal neuralgia is the one neuropathic pain that can be clinically cured, and we don't talk about it much, but it's an operation that Peter Janetta showed a lot of us, a man from America. Beautiful operation where you can make a small hole in the skull behind the ear, go over the surface of the cerebellum, and dissect the superior cerebellar artery off the trigeminal nerve, and the pain's gone. I did it on a 93-year-old. She went home 2 days later to look after her husband. It was a really great operation, and now of course we're changing a little bit.
Same principle. Yeah. Looking back at your time as Dean, which is our final photo there, what would you say was your fondest memories?
Well, the exciting thing was working with other specialists in other specialties and their absolute enthusiasm to push it. There was Michael, and there was Milton Cohen, Penny Briscoe. I thought one of the excitements is just pulling the different specialties together. When you're on just one college, like surgery, you don't see the same sort of diverse approach. And so I think we picked up a lot that way. The big thing was to try and get some of the colleges involved. Now, on the College of Surgeons, I had monumental troubles trying to get a pain section up within their national meeting. And it was restricted for fundraisings, and it took me till about 2007 before it was accepted as a pain section. And it developed. However, unfortunately, we didn't get that image raised within the College of Physicians or within the college, and they've got rheumatologists, a lot of chronic pain problems. And again, the College of Psychiatry was not very responsive, although we had some really pushy psychiatrists, like Issy Polowski was one great person. Then later it was Graham Rice, and a list of psychiatrists that were involved and committed, and they were pretty important. So I found this, in summary, the real excitement was the multidisciplinary approach and working with them and seeing it accepted and driving them.
What would you say is the thing above all else that neurosurgeons would bring to the faculty, and why is it important that we stay engaged?
Well, that's a critical question and a wonderful question, and you might not like the answer. But what we bring to the faculty is the complete failure of ablative procedures. We could see the nerve, we would operate on them, we'd cut it, and it didn't work. So a cordotomy would work for a year. And so it was good for cancer patients, but then should you be doing on a poor patient that's got a year to live? Mostly no. But I think the surgeons bring the fact, if they can remember, ablative surgery has got some restrictions. And I think it brings another thing, that we didn't have evidence for what we did, and we need to push the fact that anaesthetists who want to do procedures have evidence for what they do. And so far, I think it's a bit skimpy.
Mixed at best.
Yeah, but that tends to be forgotten because, for a lot of anaesthetists, they don't have autonomy in their lives. They don't know which patients they're going to be landed with, pushed at them, and and they've got a surgeon in the theatre who's a bit dominant, and they don't have autonomy. And so I think, there's a lot of young anaesthetists who are pretty keen to switch over to pain medicine to give them more, patient power. But if they're going to do that, then they have to think of that they need evidence for procedures, in my view.
And what would you say to a young neurosurgeon who was interested in pursuing pain these days?
Well, that is a sad thing for me, because I think I've been the only surgical dean of the faculty. The original surgeons that were involved, only a few of them got the fellowship by examination, and it's a very hard track, because what's happening now is people are going into surgery at 25 or 26. They don't get their degree till they're 35. They're going to probably have to retire when they're 65. They've only got 20 years to make a bob. And so it's very hard to say, listen, give up practicing surgery, give up learning your technique, and take a year off to do an exam. So I think we've got to find a way how the surgeons keep in contact with the faculty, because the faculty is pretty important to the surgery, and particularly if we don't learn all these things that the faculty people have learnt about suffering, disability, and all the things like workers' comp and the NDIS and medico-legal that keep pain going forever if there's a bob in it. Well, we need to be taught that. The people choosing to do spinal fusions, especially when there's 6 different ways to do a lumbar fusion, and only 36% of the people that have a lumbar fusion or workers go back to work because they all have chronic pain.
Thanks for all you've done for the faculty, Leigh.
It's been a wonderful privilege to be involved with the Faculty of Pain Medicine. And at the time of Michael Cousins' death in the last week, it's been a great privilege to recall his contributions. And it's been wonderful for me to meet people from other specialties like yourself and people in anaesthetics, psychiatry and physicians who've got different ideas, which challenging ideas to tell you, and watching how it's developing around the world. So thank you for the interview. Thank you for your courtesy. I appreciate it.